lesions. Yeah. So we need to talk about that. Anytime you come in, webcast session could not be established.
Better to have tried and failed than to never have tried at all.
Well, that's not good. So if it's important enough that they call you in to do a biopsy during the night, okay, so for those who are joining us online, we're doing Kodachromes, and as always, we give credit. There are some of the slides are courtesy of Kodas. Some of the slides are courtesy of Robert Wood Johnson School of Medicine, and the rest are mine. So, okay, so this one is not mine, and I honestly forget who gave this one to me, but it's an acutely toxic 8-year-old child. So, color morphology distribution, what do you think? Right, you want to start?
Yeah, so this is kind of like a dusky violet color, very distal, very fine scaling at the fingertips.
Oh, I know who gave this. This came from Georgetown University and Washington Hospital Center in D.C. This is from Yasmin Kapuri. So, okay, go ahead.
If it wasn't acutely toxic, I mean, I think about chilblains in this with like a finger of that color.
So you might think of chilblains, and if you think of chilblains, so you're going with, so it's always color morphology distribution. Mm-hmm. So yeah, going with the color being a little bit violaceous, you're saying chilblains, and with chilblains you always have to screen for
just connective tissue in general.
Yeah, so connective tissue with, a third to a half of chilblains people turning out to have undeclared lupus. Mm-hmm. So that's good for color. How about morphology?
It's kind of like that like retiform.
It's retiform, right? Mm-hmm. So retiform suggests possibility of what?
This is where you think about vasculitic.
So and if vasculitic, postcapillary venial side or arteriolar side? Arteriolar side, which would include what entities?
So you think about like thromboembolism. It's like your cut out.
So that's in the non-vasculitic group. So it could be embolic, thrombotic, or vasculitic. If it's vasculitic, it's on the arteriolar side, and that includes...
when you think about your medium vessel, such as your ANCA.
So your ANCA vasculitides, rheumatoid vasculitis, and septic vasculitis. And in a toxic 8-year-old, sepsis would probably go to the top of your list. Mm-hmm. In the purely thrombotic things include things like protein C, protein S, purpura fulminans, which falls into that group, is basically acquired protein S deficiency, and then things like levamisole toxicity that are thrombotic. So, so sepsis would go to the top of the list. There are a number of infarctive lesions there, and some of these are basically splinter hemorrhage, right? So you have distal hemorrhage, and reedy ridges are a peg pattern in most of your body. They are truly ridges in two areas. One is your dermatoglyphs, which are reedy ridges, right? And the second is in the nail bed, where they are truly linear ridges, which is why you get splinter hemorrhages, right? Because they just follow that ridge pattern. So there's splinter hemorrhage, which again can go with things like sepsis or bad vasculitic syndromes. You have a retiform pattern that, if blanchable, is cutis marmorata. If not blanchable, is retiform purpura. And so, you did a very nice job of saying what your differential would have been. And here is your biopsy, and your biopsy shows, tell me what your biopsy shows.
So tight perivascular. I'm thinking with ANCAs, I'm trying to see, are those granulomas? Long edge right there.
Probably, I mean, there's some limbs. It looks like there are probably some nudes and there's some karyorectic debris. So I think we make it to a vasculitis.
Mm-hmm.
And there's a lot of thrombus with the vasculitis,
Especially
which is not
right
surprising, right? Because we have a retiform purpura. Thrombotic goes in there. So things like sepsis causing purpura fulminans. Purpura fulminans can come from strep, can come from meningococcemia, can come from a variety of septic causes that young people get. So a septic vasculitis with purpura fulminans is probably top of your list. But then also, you got to remember connective tissue disease, especially rheumatoid and your ankylosing, right? And in this one, I forget. I have to check with Yasmin to see what the final. I know the kid did well, and was broadly covered for sepsis.
So if you think they did well, I think they will be good.
Well, I mean, those are usually fulminant. Those are call to the ward, life or death type of consults, and especially with the sick kid. So, okay.
So this is a diffuse alopecia. From the site, I can't tell if it's a follicular plugging or even if it's loss of follicular ostia. There seems to be an increased density of white hair. I don't know if that's secondary to the patient's age or the process that's going on.
And does the patient have uniform white hair or patchy white hair?
They have patchy white hair.
So patchy white hair suggests either the hair transformed to white or all the dark hair fell out. Right?
Yes. So I would think of this as more of a diffuse AA kind of look.
So suggests alopecia areata, where the antigen is a pigment antigen. So hair regrows white, hair changes color, and dark hair preferentially a shed. Right? So AA would be suggested. Okay. Roberto.
So, we have also the lateral brow, like very brow.
So lateral brow, lashes.
These little tiny speckles along the eyelid.
Okay. I'm not sure I see. Well, I think that's like follicular. Well, I see brow and I see lash, and I see very prominent follicle. Where follicles would have been.
So, I would think about like thyroid issues,
So thyroid tends to give you loss of lateral brows, right. As does leprosy and things like that. I don't see induration. It looks like it's more than lateral brow. Anyone else want to jump in with thoughts? Like a trichotil would be my first 80 in the differential.
Show me how you pluck it.
So, and that is exactly the key. If you ask the parent, is he plucking his eyebrows? Or ask the kid, are you? Those are confrontational questions. Show me how you pluck it. Works pretty well.
The Marshall son.
Right? Or when do you pluck it? When do you pull it? How do you pull it? Show me how you pull it. Any of those things.
I do that a lot.
But that's absolutely true, because you will get, I mean, what you're hearing is a seasoned clinician who's learned how to elicit the history rather than creating a confrontation, right? Various clues that this is not alopecia areata. One is, look how thick the hairs are. When you have someone with prurigo, you know how the hair gets thick, excessively thick and dark over the prurigo? Same thing happens with any repeated minor trauma. So the hairs tend to be very thick, very dark, very broken, very pulled. Okay.
So it looks like a skin-colored nodule. plantar surface of the toe.
Yep. So what are you thinking? Yeah, it's not the usual distribution for that, though. Supernumerary digit is usually at the base of the fifth digit, right? Sometimes, I mean, there are syndromes where you have a complete, fully functional sixth digit, but usually it's vestigial and at the base of the fifth.
Keenan's tumor, is that usually more?
Keenan's tumor, so angiofibroma, absolutely in the differential, although those tend to be more periungual in distribution, right? But the same thing histologically as a Keenan's tumor that's not periungual, that's anywhere else, is called, just like a solitary adenoma sebaceum on the face is called a fibrous papule of the face, a solitary angiofibroma. There is an angiofibroma equivalent on the digit, and what do we call that? Acquired digital fibrokeratoma. That's just an angiokeratoma of the, or angiofibroma, I'm sorry. Angiofibroma of the digit is acquired digital fibrokeratoma. It just has a different name. And just as in fibrous papule, when they're solitary, they mean nothing, and when they're multiple, they commonly mean tuberous sclerosis. Right? When you have them on the penis, they're called pearly penile papules. They're angiofibromas. When you have them on the digits, they're called acquired digital fibrokeratoma. It's an angiofibroma. Fibrous papule is an angiofibroma, adenoma sebaceum. They're all the same lesion, essentially just in different locations. So multiple angiofibromas are associated with tuberous sclerosis. What else are they associated with? Common things. You can see them in bird hog Dubé. You can see them in multiple endocrine neoplasia and usually type 1. So those are probably the most common things outside of TS. Okay, how about this guy?
So on the posterior neck,
okay, so, and how would you describe this morphology? Arcuate, or if it forms a complete ring, annular. So arcuate and annular lesions. Round is circinate. Donut is annular. Partial donut you've taken a bite out of is arcuate. So, and then is your center normal or is your center not normal? And what things may be abnormal about the center? So is this skin wrinkly? Is that skin wrinkly? What might be absent in wrinkly skin? Elastin. So do you know any annular elastolytic process? So anyone want to jump in? Yeah, the other name for actinic granuloma is annular elastolytic granuloma. So when you have things that are indurated like that with no surface scale, and they're pink, it's commonly a granulomatous process. One of the ways you can tell is do diascopy. You squeeze all the blood out of it. What's left is the carotenoids and cytoplasm, so you get apple jelly look because you're seeing lots of yellow cytoplasm. So you'd expect that this would look granulomatous, apple jelly on diascopy. It's wrinkly in the center, suggesting elastic tissue has taken a hit. So annular elastolytic granuloma, which is also actinic granuloma. Right? Same, two names, same thing. So ulcers full thickness. You think you're full thickness, or you think it's more surface erosion or surface necrosis? So hyperpigmentation and is it just brown? Yeah, so hyperpigmentation and erythema. So a base of erythema and hyperpigmentation, and then surface slough and necrosis. So what kind of things would be in your differential? So color morphology distribution, you did color pretty well. Morphology, they're not purely round. There's some irregularity to shapes and also to the area of slough. And then distribution, it's not so much medial leg where you might expect stasis to be most prominent. Upper ears thoughts? So possibility that it could be vasculitic and you don't have complete ulceration, I think absolutely. So you put it into possibility of a retiform necrosis, differential, thrombotic, embolic, vasculitic. Other things you might want to put in there?
Myxedema.
I'm sorry, say it again.
Pretibial myxedema, but I don't know if that would break down.
Pretibial mix, it's a little maybe patchy for that.
I don't really think of it as being ulcerated, but like pigmented purple, like lichen aureus or something.
So lichen aureus, but again, as you said, the breakdown, the slough would be unusual distribution of a fixed drug, something infiltrative, either tumor, leukemia, if that were an infiltrative lesion, necrolytic acral erythema, associated with hepatitis C, nutritional deficiency, you'd want to look at other parts of the body. That's probably a good broad differential. Here's your path. So what do you think you're seeing in path? Kind of a surprise, right? Because that looks granulomatous, right? So then granulomatous things would include infectious granulomas, sarcoid, so TB, leprosy, all of those things, atypical mycobacteria, and this one we have to hit escape. I don't have notes on there. So someone gave me the slide. It is always about the differential. But that's where you would get, I can actually check my notes at home. I can probably tell you exactly what it turned out to be when they worked it up.
You can't 1x these?
It looks granulomatous, so, and it's around neurovascular bundles, so it absolutely could be leprosy, could be tuberculosis, could be atypical mycobacteria, could be, so infectious granuloma and sarcoid is basically where we are. Like a Becker's nevus, so hypertrichosis and hyperpigmentation, Wolfman patch on the shoulder.
Wolfman. I mean,
a very ill small adult or
agreed.
A child?
Well, I consider all children small adults, but yes,
Some
sickly
more than others.
child.
Okay, so probably a very ill child.
Yeah, with this weird, like they have very thin skin, obviously, globoid, and looks like this weird kind of yellow-white depositional.
Yeah. So what kind of things could it be?
Bony-looking weird thing there.
So bony looking, so you're thinking bone or maybe calcium?
Yeah.
So what would be your thoughts?
I mean, that's a weird spot. Can you have like a, I don't know, man.
So it could be a dystrophic calcinosis cutis, could be osteomacutis. Let's see if we have...
I just think they would be trying to tell you the spot.
And it was calcinosis.
Okay.
It was calcinosis cutis.
Okay.
So,
It's right in your white, yellow, bony diff.
Most likely dystrophic in this case, and you can get that site of injury.
Right.
Someone with atrophic tissue. Okay, this one came from Ohio State, and I believe there is a second image that's kind of shocking. So if you have a queasy stomach, you may not want to look at the upcoming image.
Chloracne.
So chloracne is exactly what it looks like, right? And a localized chloracne is usually from.
Well, we just talked about smoking over the face, but
that's exactly what localized chloracne is most likely from. So I think we have the image there. So he was just showing you how addictive smoking is. He has completely lost all of that tissue to cancer, and to allow himself to continue to smoke, he basically holds a cloth over the area so that he can put the cigarette in there and inhale through what's left of his nasal cavity. So, it is a powerful, powerful addiction, and that is all localized chloracne from the smoke.
This is it looks like shiitake mushroom.
Okay.
We have really thickened hyperkeratotic growth on the distal extremity, foot, and toe. It looks like you're almost getting pseudo-anheim or actually distal loss of
So
the
like
toe.
suitor, einem, I've heard it pronounced different ways. Anaheim is where Disneyland is. Okay.
I don't know what this is. I obviously feel like it's probably some sort of genodermatitis.
So some kind of genoderm would be in the differential. Are the nails normal or abnormal?
The nails are not normal. They're significantly dystrophic.
And is the periungual tissue normal or abnormal?
It's also abnormal.
And your main abnormality is hyperkeratosis, right? So what do you know of that gives you massive hyperkeratosis around the nails?
Well, I'm sure it's some sort of chondrocardia, but it's outside of that vein.
So you're thinking of genoderms of some sort, but outside of genoderms, acquired things, common things being common. You get called to the ward. It's the patient's canceled. We send out an email. I'm so sorry if you didn't get it. Okay. So you get called to the ward, and the patient just has nails like that. So delete the skin and just look at the nails like that.
So like fungal or psoriasis or.
Although those don't tend to do proximal nail fold as well. What gives you periungual hyperkeratosis around the nails?
Missing what it is.
Their ears often. Missing the diagnosis carries its own penalty.
Oh, scabies.
Wow.
Scabies.
Oh
Just massive hyperkeratotic scabies.
That's the craziest picture in the
would be their finger because of scabies, or their toe because of scabies?
It's just massive hyperkeratosis, and you're seeing fissuring.
Yeah.
There. So that was all. Again, this is not my slide. This was donated, but
dude, that is the word.
Just.
But
dissect down. If you look at color morphology distribution, right? Crusted scabies can be any hyperkeratosis can be dark. Crusted scabies often is that startlingly white silver, and it has areas of that, right? Plus the periungual hyperkeratosis.
The pictures of crusted scabies that we've seen have been like the arm would be like
it
a
looks
diffuse
just like
scale versus like this pelagonal kind of ichthyotic.
That's why we do clinical images, right?
That is shocking.
Have you seen anything?
Have I seen? I've seen it about this bad. Yes. And all different variants. Silvery on the ears. Scabies. Bill James, for his graduating residents, I've been told, he does one slide session that is the things that will make a fool of you in your first year. And it's every morphology of tinea and scabies you can imagine. Right? Common things are common. Okay, let's move on.
Right, so we have this very large annular mass on the shoulder.
And I think that last one was a Robert Wood patient. They see incredible range of pathology there. So I'm sorry, go ahead.
So it's just like a large annular pink to red plaque.
Yeah, so certainly annular. And is the surrounding skin normal or not normal?
No, it's not. It's kind of a yellowish color along with this kind of blue-gray hyperpigmentation.
Yeah, so I'm guessing that the patient has pigment native to their skin, right? And we're seeing lots of hyperpigmentation and patch and plaque type lesions, and then an indurated annular lesions. What are you thinking?
I would think of like malignancy.
Specifically, what? So you have a
CTCL.
CTCL would be top of your list, absolutely. So annular and gyrate lesions, you think of CTCL in your differential, and you think of syphilis in your differential. So both of those would have to be entertained. It looks like there is a lot of chronicity here, and CTCL disproportionately affects African Americans, disproportionately as a working man's disease, and and the morphology certainly fits. A person with pigmented skin, patch, plaque, hyperpigmented, and annular indurated lesions certainly fits for CTCL.
What would you use for advanced?
I'm sorry?
No choice for like advanced CTCL.
Oh, well, it depends. Even at advanced, if they've never been treated, they can respond beautifully to methotrexate. They can respond to light. Anything you do that doesn't adversely affect their immune system is to their benefit. Then you still can do mustard and interferon. And then, there are a host of Renistat and other agents now available, but you still try with the basics because most patients still respond, and not tinkering with their immune system is the best favor you could do for them. So, okay. Color morphology distribution.
Cercinate, nodular.
So cercinate, many of them with central necrosis, right? Some to the point of eschar, others just to slough, right? So cercinate lesions, pink to plum, maybe even violaceous. So what things are in your differential? So lymphoma is probably your top four. And then after that, you'd have to think of infectious things, possibly vasculitic, less likely. These are really beautifully circular. So probably something infiltrative neoplastic and probably lymphoma spectrum. And then do you think this is more likely a cytotoxic or a non-cytotoxic lymphoma? I see lots of evidence of cytotoxicity, right? And what's the course of cutaneous cytotoxic lymphomas? Usually abysmal, exactly. So within 3 months, they'll look like a TEN patient and usually succumb to their disease. So that is exactly what that was, unfortunately.
So there's like more CD8 cells?
Yeah. So CD8, there are indolent CD8 processes, and they're very aggressive. So this is the aggressive cutaneous cytotoxic lymphoma, which are CD8 positive and is horrible disease. You will die of sepsis, and you just can't survive the breakdown of tissue.
Gamma delta or gamma deltas?
So gamma deltas are different. So gamma deltas are usually subcutaneous, dermal, and epidermotropic, all three. and gamma deltas are also aggressive lymphomas. You usually see lots of karyorectic debris that is degenerating cells, not neutrophil, not leukocytoclasis, but karyorexis from the tumor cells. So they're dirty appearing lymphomas and also aggressive. So when you have a sub-Q lymphoma, they're the alpha beta ones, which are very indolent, and they're the gamma delta ones, which are anything but indolent. And so that's important to differentiate. Okay.
So in that villa we have what look like atrophic scar-like areas. We don't have some sort of wide pathways.
So there are little bits of white here. Maybe some of that may be deodorant sitting on hair follicles. I'm thinking maybe stick rather than roll on. And then there's erythema. There are what look like sinus tract type of openings and comedone-like openings, and there's excessive brown, right? There's a brown pigment, and the brown pigment is somewhat reticulated. Do you know of any pigmented reticulated anomaly that affects the flexures? Pigmented reticulate anomaly of the flexures, which is also called Dowling-Dagos. So Dowling-Dagos would be up there. You might also think, hidradenitis,
Like dormant.
hidradenitis suppurativa that's not active with some hyperpigmentation. What else are you thinking?
I would have guessed the chest.
Yeah.
I don't like inflammatory pigmentation.
LP pigmentosa, possibly. The question is what's causing the sinus tracts, though. That wouldn't usually be and LP pigmentosa is usually, what's the distribution? Is it sun-protected areas or sun-exposed areas? It's distinct ethnic types, especially South Asians, Southwest Asians, and which means Middle Eastern, Indian, Pakistani, right? And usually face exposed, photo-exposed areas. That's a little closer, and this was Dowling-Dagos. But a lot of the Dowling-Dagos, they'll get inflammatory lesions. Those cysts become inflammatory, and when you look at them, you got that differential of hidradenitis as well. Yeah, I'd say, in terms of follicular plugging, is it more follicular plugging or more loss of follicular ostia? Looks pretty smooth and glossy to me, right? Like loss of follicular ostia. So it could be a diffuse AA that's, very extensive. That usually will give you preservation of follicular ostia. But sometimes that can be tough to tell clinically. One of the things you can do is just see what comes out voluntarily of the hair or the bag the patient brings in and look for tapered fractures, which AA would give you, right? So you want to know how active their shed is as a clue to that and whether there are tapered fractures in the shed. Other things would be, then you're in the scarring alopecia realm would be the other big thing. There is some patchiness to it here. So a very advanced pseudopelade could look like that. LPP can leave very little visible scar, unlike lupus, which tends to give a lot of dyspigmentation and a lot of surface change. And this one was AA, diffuse. So another lymphoma, which one in particular giving that we are in limb girdle area, and there are patches greater than 5 centimeters, as well as plaques and tumor. So cutaneous T-cell lymphoma, mycosis fungoides, absolutely would be top of your list.
So it's like a tumor here, and the
It's like a
orbital
tumor.
rim.
What would you do?
I'd call Big Daddy. Dr. Cook, probably biopsy it.
Probably biopsy it.
That's the
Okay,
first
very
step.
good. That
Make
would
a
be your
packet.
first step. Okay. There's your biopsy.
Yep, that's what I suspected. Rodent ulcer.
So you suspect basal cell, except that is a melanoma.
That's a little bit of a curveball. Well, that's weird. So it's melanoma.
So you go back to it clinically.
I mean, it's pretty brown. Could be
So
pigmented basal.
look over here. This area has little flecks like a pigmented basal cell. This area has an
More of
irregular
a
pigment
LM
network.
look,
Exactly. And then look at the rest of this. That's basal cell. This is all indigo maligna, and it's colonizing.
That's interesting.
So when you look at it,
Still like call
look
something
at your
the
macular. Yeah, everyone looks at the slide and is drawn to the obvious basal cell, right? But look at your macular
Ginger
pigment
violet.
around it, because management then becomes very different, right? Yeah, it looked like the guy was older. But so collision tumor, melanoma, and basal cell. Okay.
So very indurated, red violet.
Yep.
Leg.
Very good.
Yeah, man.
Looks like you got areas of erosion, and that almost looks exophytic on the posterior aspect there.
Yeah, so that's probably an ulceration, and adjacent to it is the color normal, or is the color dusky?
No, it's dusky.
So you have necrosis, probably necrosis with ulceration, and then you have numerous spots where what's happening. So it's lumpy, bumpy, and indurated.
Right. I mean, it kind of had that Botrytis look to it. With
Yeah,
little sinus.
exactly. So little necrotic sinus tracts, right? So you're describing botryomycosis, mycetoma. That's basically what you're describing is a mycetoma, botrytis. Again, we give it different names. If it's staph, we call it botryomycosis. If it's a foot, we call it Madura foot. If it's elsewhere, you call it mycetoma. Lumpy jaw, when it's on the jaw, it's all the same thing. So it tends to be an infection that could be staph. More commonly is fungal, right, in origin. Often dematiaceous fungi. And that one was it was fungal, and I think this one was a FAO.
So this is a child with diffuse erythemas to brown macules and papules. One that seems to be wheeling up, or a few that seem to be wheeling up. So I would think that this is possibly either UP with like a Derrier sign, or LCH. I guess we probably might differentiate.
So UP and LCH, and when you look at it, what's the distribution here? Do you think? And do you think? And a lot of these are papular. Okay. And do you think they correspond to anything?
I'm sure like hair follicles.
Like follicles. And of the things you described, which one is more likely follicular? LCH. So the clinicians absolutely were thinking LCH, and so they biopsied thinking LCH. You've got reniform nuclei, you got EOs. They are all CD1A positive. So this child was admitted to a very good university hospital in the United States and started on chlorambucil. That is this, and you're absolutely right. So, and when you go back morphologically, so there have been lots of kids treated with chlorambucil for scabies, and then one, it doesn't work for the scabies, and two, there's a 10% risk of leukemia now that you've been treated with chlorambucil for LCH that you didn't have. So, it's really, really bad all around. These were smart people involved, but it's one of my really good attendings in internship said, never fall in love with your diagnosis. You always keep that open mind. What else could it be? Which is always why we're doing color morphology distribution. And Dr. Mays forces you to put at least one thing in every bucket: infectious, genoderm. Is there anything from any bucket that could cause this morphology? Just so you're keeping an open mind to other possibilities.
How was it discovered that scabies debate?
So the true story is this was sent in. We were running a national conference, and everyone sends in their cases for CPC, like Atlantic Derm, Pacific Derm, Southern Derm, Zola Cooper. All the conferences run that way, right? So every university is sending in their best cases, and Les LeBeau, who was doing a lot of the grunt work to put it together, got all the slides cut and was sorting them, so everyone who submits a case gets a full set of all the cases for the CPC. And he was reviewing every slide to make sure it had pathology, and the mites showed up in the deeper sections, which meant a phone call to the university to tell them their patient had scabies.
Can you guys take clinical photos for us?
Yeah. You can see excoriations. If you think scabies, you can now see, of course, that's scabies in a kid, right? But remember, scabies can massively recruit CD30 cells, can massively recruit Langerhans cells, so can tick bites and things like that. So you can get fooled into lymphomatoid papulosis, you can get fooled into scabies, and we're right at the end of the conference. So we're going to stop on that slide. And so our slide number for the next one, several people put it down. This is set 5.
839.
Number 39.
That was some good sleeping.
Okay, very good.
What is it again? 39.
Number 39, set 5. If numerous people put it in their phones, that'll work. Okay, and goodbye to everyone who joined us online.